hematology, oncology, other anemias. This audio recording is going to be focusing closely to non-hemolytic normocytic anemias that don't really fit in with any other microcytic or macrocytic anemias. And they also don't fit in with any other hemolytic anemias or non-hemolytic anemias. And the two that we're really going to be focusing in on today is going to be the anemia of chronic disease and aplastic anemia. So to begin with, the anemia of chronic disease is going to be secondary to any chronic disease. And when we have a chronic disease, that constantly leads to chronic inflammation. So that is a connection that we need to make automatically. If we have any type of chronic disease, and that could be, lupus, SLE, rheumatoid arthritis, those are two great examples of chronic diseases. Those lead to chronic inflammation. And when we have chronic inflammation, we know that there's going to be an increase in IL-6, which we'll discuss later on in immunology videos. But that increase in IL-6 leads to an increase in acute phase reactants or acute reactive proteins, okay, so ARPs. And one specific type of ARP is hepcidin. And hepcidin, what it is it's released by the liver and it binds to ferroportin normally. And what ferroportin does is that it allows for absorption of iron from the GI tract. And so with hepcidin blocks the ability for ferroportin to do its job. And so this leads to a blockage of iron being absorbed from the GI tract and iron being released from its storage sites within macrophages. And the reason we do this is just because evolutionarily, we have our body protecting itself from bacteria that use iron in order to create reactive oxygenative species through the Fenton reaction. So our body has said, okay, if we're constantly in an inflammatory state, we feel like there is an invader around. So what do we need to do? We need to block the ability for it to acquire iron and use it to hurt ourselves. So how does it do it? It increases hepcidin, and hepcidin blocks ferroportin, meaning that we will no longer bring in any iron and we will no longer release any of our iron storages. So what type of findings will we see? We'll see a decrease in serum iron, a decrease in total iron binding capacity because there's not much iron transported in the blood. And we're going to have an increase in ferritin because we want to keep the iron in with ferritin, okay? And this is all due to the fact that we have chronic inflammation secondary to some type of chronic disease. Once again, like lupus or rheumatoid arthritis or autoimmune, or it could be chronic kidney diseases. Those are the most important ones that we'll be talking about. So the way that we treat this is we just have to address that underlying cause of inflammation. Whatever it might be, we have to fix that inflammation in order to lead to decrease ARPs, which leads to decrease hepcidin overall, which is produced by the liver. And then we can have normal and we can get rid of our anemic symptoms. The second anemia that doesn't really fit into a box is aplastic anemia. And all that is that it's going to be destruction of our hematopoietic stem cells at the bone marrow. And the number one highest yield association for aplastic anemia is going to be our parvo B19 virus. And what we need to understand about this is that patients that present with already serious anemias, okay? So for example, sickle cell, which we'll touch on, or beta thalassemia major, those are serious bone marrow abnormalities that already cause us to have anemia. Now, if we add something on top of it that attacks our hematopoietic precursors, our hematopoietic stem cells, we're adding fuel to the fire. So we have a huge problem now because we're destroying all of our hematopoietic stem cells. We're no longer able to create those blood cells, but we're already at a deficit when patients with sickle cell disease come in or patients with beta thalassemia major come in. So you got to be careful with previous bone marrow abnormalities or anemias, and then they get this viral infection like parvo B19, which specifically attacks those precursor cells for blood cells. What we're going to see on findings is decreased reticulocyte count, because remember that decrease in reticulocyte count just tells us that there's a decrease in the ability for the bone marrow to create more cells. Okay? Very important to understand that. There's other things that can cause aplastic anemia, some of which are radiation, Fanconi anemia, and drugs. But once again, the highest yield thing that we need to know is that parvo B19 virus. Lastly, for aplastic anemia, what we have to understand is that on bone marrow biopsy or bone marrow tap, we're going to see an empty bone marrow. They'll call it cobweb bone marrow or hypocellular bone marrow with fatty infiltrate. And the reason that we see this is because we've killed all the precursor cells. So all that's left is just fat in the bone marrow, and it gives an appearance of cobwebs.